Now, very importantly, we are going to discuss the thromboelastogram, and this is very important from your practical exam point of view. It was asked in the last year. So today in this year, we are introducing this thromboelastogram. This is a known reference plasma, whereas this is basically test plasma. And over here, we have already taken a factor deficient plasma. Now, factor deficient plasma is already available. Okay, it is known. It is a known factor deficient plasma is taken. Now, what is happening? First, try to understand. Myself, Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important session. In today's topic of discussion, as you have already seen from the thumbnail, we are going to discuss the approach to bleeding disorder. So, this is a very important topic from exam point of view, because a long answer question is asked directly in the exam: approach to bleeding disorder. Okay, the second important question which can come, okay, related to this topic is: how do you differentiate between bleeding because of platelet vascular disorder versus bleeding because of a coagulation disorder? That is another long answer question which is asked. And the third and the most important LAQ which is increasingly being asked, okay, today, that is thromboelastography. Okay, so what is the concept, what is the mechanism, what is the principal use of thromboelastography, and more importantly, in your viva, the examiner are bringing a characteristic thromboelastogram. Okay, and they are asking you to interpret, and they are asking you what is the R value, what is the K value, okay, what is alpha angle. So all these are very important questions which are asked in the viva exams. So these are the three important things that we are going to discuss in today's topic of discussion. So without wasting any time, let us begin today's topic of discussion. So first thing, whenever a patient comes to you with bleeding, the first question that you ask yourself, whether it is a bleeding disorder. Okay, whether it is a bleeding disorder. Now you have to understand that usually, okay, minor cuts, for example, you are working inside a kitchen, you are cutting vegetables, okay, you are cutting fruits, so sometimes minor cut can occur. Okay, or your child is playing inside of school, okay, so sometime while playing they fall down, they have minor cuts. So these are something which is usual and you come across them in a day-to-day basis. Okay, so that is all right. But if you see any red flag signs, okay, any red flag signs, like if there is any spontaneous bleeding or bleeding which is occurring because of a very mild trauma, which in usual individuals is not causing any bleeding, or bleeding occurring, if there is very easy bruising is occurring. Okay, so basically, okay, all these things, these are flag signs which is pointing towards a bleeding disorder. So any spontaneous bleeding or bleeding secondary to a mild trauma, or there is very easy bruising, okay, so it is pointing towards a bleeding disorder. If there is a repeated episode of bleeding, so patient is giving you a history that again and again I am having, there is bleeding, or there is epistaxis from the nose, okay, or there is some kind of bleeding, or there is pinpoint hemorrhage always in some part of the body here and there is repeated episodes is there, or there is bleeding from multiple sites, or the bleeding is disproportionate to the degree of trauma. So for example, you are having small cut, okay, so in usual individuals in 4 or 5 minutes the bleeding will stop, okay. But for example, the bleeding is going on for a very small minor cut of the bleeding is going. So the bleeding is disproportionate to the degree of trauma. Or characteristically, the patient is giving you a history of delayed bleeding. Doctor, I had gone to my dentist, okay, around 2-3 days before, and after 48 hours of the procedure, I am having some kind of bleeding. Or there is a delayed onset bleeding. This is a very characteristic sign of bleeding because of coagulation disorder. Okay, so whenever you are having such a history of a spontaneous bleeding because of a mild trauma, easy bruising, or repeated episodes of bleeding from multiple sites, or bleeding disproportionate to the degree of trauma, or delayed onset bleeding. So whenever you are having such kind of patient history, in that case you have to go for a detailed physical examination and history taking of the patient. Okay, so by taking a detailed clinical examination, you can understand what is the nature of the bleeding, whether it is a platelet or vascular bleeding, or it is a bleeding secondary to coagulation defect. So you go for the physical examination. So during a physical examination, if you see that there is a petechiae. So what is a petechiae? Petechiae is a tiny pinpoint hemorrhage which is less than equal to 2 mm in size in the skin or mucous membrane. Or if you see that there is a purpura. Now purpura, these are slightly larger hemorrhage ranging between 3 mm to 1 cm in size in the skin or mucous membrane. And both petechiae and purpura, they are small and they are multiple. Or for example, if you see that there is epistaxis, epistaxis is that is bleeding from the nose, okay, mucous membrane of the nose, that is epistaxis. Or there is melena in your stools, bleeding in the stools, or there is bleeding gums, okay. So all these, petechiae, purpura, epistaxis, melena, bleeding gums, all this is suggestive of platelet or vascular disorder. It is suggestive of bleeding secondary to platelet or vascular disorder. Now, I have already shown you how a petechiae looks like, how a purpura looks like in my lectures on the bleeding disorder part 1. So, I am not repeating that again. So, please go back to that lecture to see, okay. So, if you see petechiae, purpura, epistaxis, melena, bleeding gums, so this is suggestive of bleeding because of a platelet or vascular disorder. On the other hand, if you see large areas of hemorrhage, okay, so the area of hemorrhage is more than 1 centimeter in the skin, then we are calling it as ecchymosis, and this ecchymosis is large but they are fewer. They are larger in size but they are fewer. If you see that there is any kind of a hematoma, that is there is a large hemorrhage. What is the hematoma? Hematoma is when there is a large hemorrhage which is collecting subcutaneously or intramuscularly, it is called as a hematoma. Or there is a hemarthrosis whenever there is hemorrhage, which is whenever there is bleeding into the joints, we are calling it as hemarthrosis, okay. So whenever you see hematoma, okay, there is a hemorrhage, large hemorrhage subcutaneously, or there is a collection of blood, inside the muscles, intramuscular hematoma or subcutaneous hematoma, or you come across hemarthrosis or ecchymosis, then they are suggestive of a coagulative disorder. Then they are suggestive of a coagulative disorder. So this is how by physical examination you can differentiate between bleeding because of a platelet vascular disorder or bleeding because of a coagulative disorder. Then again there are certain other types of bleeding which is also throwing light, like for example umbilical stump bleeding or defective wound healing is suggestive of bleeding because of factor 13 deficiency. Or there is recurrent severe epistaxis, it is suggestive of hereditary hemorrhagic telangiectasia, okay. So now after you have gone for the physical examination, so now you also have to take certain further important history has to be taken to rule out any kind of acquired or any kind of inherited bleeding disorder. Not to rule out, but to differentiate whether there is any history of an acquired acquired cause of bleeding or any history of an inherited cause of bleeding. Sometimes the patient will come to you and himself will say that I am a hemophilic patient, okay, I am having this, or I am this and that patient. So already the patient will give you the history about that. So you have to differentiate whether it is an acquired or it is an inherited cause. So acquired cause means if you look for any severe liver disease or any drug history, like history of taking heparin, warfarin or aspirin. So heparin, parenteral oral anticoagulant is warfarin, okay. Then history of any renal disorder is there, any malignancy is there. As you remember that adenocarcinoma, the mucus produced by them, or even in APML, they can trigger bleeding secondary to disseminated intravascular coagulation. So secondary to DIC they can show bleeding, or severe kind of infections, okay, they are also one of the acquired causes. They can cause bleeding secondary to vascular wall damage, as well as endothelial activation can be there, or because of malabsorption, okay. So you have to rule out all these acquired causes, okay. Then you can also take the patient history to see if there is any inherited component or any family history is there. So if close, so how you can understand whether whether any inherited cause is there or no. So you ask whether any of your family member or any of your close relative have the same bleeding disorder. So if close family members or relatives have the same bleeding disorder or no, you have to see. So how do you come to a diagnosis? So number one, if there is a history of bleeding only in case of males and on the maternal side, then it is it is quite suggestive of an X-linked disorder. And among the X-linked disorder, hemophilia, that is factor number 8, or hemophilia B, that is factor number 9 deficiency is very common. So factor number 8 or 9 leading to hemophilia A or B is very common. So if there is a history of bleeding among the males or among the maternal side, it is suggestive of X-linked disorder like hemophilia, factor 8 or factor 9 deficiency, okay. Factor number 8 deficiency called as hemophilia A, and factor number 9 deficiency called as hemophilia B. Now if there is a history of consanguineous marriage, and if you see that in the family tree both the sexes are affected, there is no sexual predilection, and parents may or may not be affected, then in that situation it is suggestive of a autosomal recessive disorder. For example, type 3 von Willebrand disease or A fibrinogenemia, okay. So these are autosomal recessive disorders. or if you see that at least one of the parent is affected, okay, or both sexes are affected over here, so it is suggestive of an autosomal dominant disorder like type 1 and type 2 von Willebrand factor disease or von Willebrand disease. Okay. Now over here, from the clinical examination, from the patient history, you get a fair bit of an idea that what is happening or what is not happening. So after that, to get confirmation and to further consolidate, okay, your diagnosis, you have to go for a certain screening test or certain specific laboratory test. So you have to go for the lab diagnosis. So there are certain screening tests of bleeding disorders, like to carry out a normal CBC, including the platelet count, peripheral blood smear examination. Okay, you go for the BTCT examination, bleeding time, clotting time. Then you go for prothrombin time, activated partial thromboplastin time, or thrombin time. And very commonly you go for the platelet function analysis or analyzer test, PFA 100, 200. Okay, or you have certain specific tests like platelet function test. Okay, then you are having clotting factor assays. Okay, test for fibrinogen, FDPs, D dimers are there. And lastly, we are having global hemostatic test, that is thromboelastography or thromboelastometry. Okay, rotational thromboelastometry. The very important thing is over here you have to understand that we have already discussed in details in the bleeding disorders part 2 about the platelet function test. Okay, so you please, for platelet function test, you please go and you see the platelet function, the bleeding disorders part 2 lecture for platelet function test, and PFA or platelet function analyzer has been discussed as a part of PFT already. Okay, so please go that particular lecture and please see that lecture. So whenever you are asked a long answer question, please don't skip this part. You have to write about the platelet function test also, which has been discussed already in bleeding disorders part 2. Okay, so now we are going to see, okay, now how do you differentiate between a platelet vascular disorder bleeding versus bleeding because of a coagulation disorder. So if you see, look at the bleeding site. Okay, if you look at the site of bleeding, in case of platelet vascular disorder, usually bleeding affects the mucous membrane. So you will see mucous membrane is bleeding, or you will see the bleeding gums or nosebleed, that is epistaxis will be seen. You will see bleeding in the form of petechiae, or you will see bleeding in the form of purpura you will see. Okay, and bleeding is occurring from multiple sites. Whereas in case of coagulation disorder, the bleeding sites, they are limited to the joints and muscles. So as you know, bleeding into the joints, it is called as hemarthrosis, whereas that into the muscles is called as hematoma, and bleeding is localized. Coming to the bleeding onset, as I told you that characteristic delayed onset of bleeding is seen in case of coagulation disorders, whereas delayed onset of bleeding is not seen in bleeding secondary to platelet or vascular disorder. If you look at the sexual predilection, bleeding secondary to platelet or vascular disorder, it is more common in females, whereas that because of coagulation disorder is most common in males. A family history of bleeding is rare in bleeding because of platelet or vascular disorder, whereas it is common secondary to the coagulation bleedings. Okay. Now the treatment response in case of bleeding because of platelet or vascular disorder, the treatment response is immediate, whereas the treatment response is gradual in case of bleeding secondary to coagulation disorders. And the skin hemorrhage, they are very small and they are many, they are multiple in case of your bleeding because of platelet or vascular disorder in the form of petechiae, purpura, whereas the bleeding area, okay, in the skin is very large and few in case of bleeding secondary to coagulation disorders, especially for example is your ecchymosis, okay. So with this we have completed the first part of the lecture, or the first first part wherein you have got a basic idea as to how to approach a case. Okay, now we are going to go into the individual laboratory tests. So the first line of investigation are the screening tests. So let us look at the screening test. So the first thing that you will do is to go for the CBC and the peripheral blood smear. So you will look at the platelet count. So it helps us to it helps us in the evaluation of thrombocytopenia. So CBC and the peripheral blood smear examination is very important in the evaluation of thrombocytopenia. So whenever you are having thrombocytopenia, an arbitrary mark of 1,50,000 is kept for thrombocytopenia. So anything less than 1,50,000 is called as thrombocytopenia. You go for the peripheral blood smear evaluation. Okay, in the PBS evaluation you have to see whether any blood cell abnormality is present or no. So if the blood cell abnormality is present, for example, the first important thing, if you see that there is a platelet clumping or there is platelet satellitism, that is the platelets are surrounding the WBCs or any white blood cell. Okay, it is suggestive of a pseudo thrombocytopenia or artifactual thrombocytopenia which is occurring secondary to EDTA induced platelet clumping or satellitism. Okay, it is very commonly and most common cause of thrombocytopenia actually, if you see. Secondly, if you see, there is macrocytosis, RBCs are bigger in size, so they are suggestive of megaloblastic anemia. If there is a pancytopenia, okay, it is suggestive of aplastic anemia. So for definitive diagnosis, you have to go for bone marrow biopsy. Similarly, if you come across any abnormal WBCs like blast, so you are thinking of leukemia, or if there is any abnormal WBCs like pseudopelger anomalies are there. Okay, so in that case also for confirmation you have to go for bone marrow evaluation. Or for example, you see any kind of hemolysis is there of fragmented RBCs or cystocytes, so it is suggestive of microangiopathic hemolytic anemia picture is there. Okay, so what are the causes of MAHA? We are having TTP, HUS and DIC. Now remember, TTP, HUS, even though TTP, HUS is characterized by microvascular thrombosis, over here the test of coagulation is normal, whereas in case of DIC the test of coagulation is abnormal. So if you see hemolysis, fragmented RBC, cystocytes, okay, you go for coagulation testing, that is you go for PT, APTT, all these testing you do. Now in this case, if the coagulation screen comes out to be normal, it is suggestive of TTP, HUS, whereas if the coagulation screen is abnormal, then it is suggestive of DIC. So remember one thing, it's a very important MCQ that TTP and HUS, even though there is microvascular thrombosis, remember one thing that over here in TTP and HUS, the coagulation profile is completely normal, okay, or the coagulation screen PT, APTT is normal and TTP, HUS, okay. Now also one thing in the peripheral smears that you can come across is the giant platelets. What is the definition of giant platelets? I have already discussed in my lecture of normal hematopoiesis. Okay, so if the size is larger than the nucleus of a small lymphocyte, okay, these are called as giant platelets and they are mainly suggestive of accelerated thrombopoiesis secondary to platelet destruction. Okay, but there can be many other causes, but this is one of the most common causes. Okay, so this is the first line, the first investigation, that is the complete blood count, okay, including the platelet count and the peripheral blood smear evaluation, and it helps us to evaluate thrombocytopenia along with its causes that we have already discussed. Second important point is the bleeding time. Now bleeding time assesses both the platelet as well as the blood vessels. So it is assessing both the platelet activity as well as the blood vessels. Therefore we can say that they are a good measure of primary hemostasis. Okay, the normal bleeding time is 2 to 6 minutes. So how do you calculate the bleeding time? A puncture is made of the skin and the time which is needed for bleeding to stop is recorded. Now bleeding time is prolonged in case of thrombocytopenia if the platelet count is less than 1 lakh per cubic millimeter. Remember, the test is not done. Okay, so it is prolonged in thrombocytopenia, in disorders affecting the blood vessels, in von Willebrand disease, and if any platelet function abnormality is there, then also the bleeding time will be prolonged. So how do you evaluate a case of prolonged bleeding time? So if there is a prolonged bleeding time, you look at the platelet count. If the platelet count is reduced, you go for a bone marrow evaluation. If in the bone marrow evaluation there is normal or increased amount of megakaryocytes, it is suggestive of increased platelet destruction. And if there is a reduced amount of megakaryocytes, it is suggestive of reduced platelet production. On the other hand, if the platelet count is completely normal with a prolonged bleeding time, it is suggestive of von Willebrand disease or a vascular disorder or a platelet function defect. Okay, is this point crystal clear to everyone? Now remember, the test for bleeding time or BT is not done routinely. Why? Because it is quite invasive test. Okay, and secondly, it lacks sensitivity and specificity, and it lacks reproducibility. That means the test result from one lab may not match with the same test result from another lab. So it lacks reproducibility and it is quite cumbersome to perform. Okay, so therefore it is avoided. It is not routinely performed. BT is not routinely performed. Then the third important test is your clotting time. Now clotting time basically measures the time which is required for the blood to clot in a glass test tube at 37 degrees centigrade. Now clotting time, again, this is no more or no longer done. It is replaced by APTT. Now clotting time is prolonged only in severe deficiency of clotting factors and is normal in mild or moderate deficiency of clotting factors. Remember, one drawback of clotting time is it is prolonged only in severe deficiency of clotting factors and it is normal in mild or moderate deficiencies. Okay. The next important parameter that we are going to see is the prothrombin time. And remember, prothrombin time many a time is asked as a short note in the exam. Okay, so please pay a lot of attention. So prothrombin time, okay, it assesses the clotting factors of the extrinsic and common pathways of hemostasis, and these pathways are basically the in vitro pathways of hemostasis. Okay, so it is assessing the clotting factors of the extrinsic and the common pathways. Now extrinsic pathway means it is mainly assessing the factor number 7, and common pathways means it is going to assess factor number 5, factor number 8, prothrombin, which is nothing but factor number 2, and fibrinogen. So how do you carry out the test? You take tissue thromboplastin and calcium, okay, and to that and you add that to the plasma which we are testing. Plasma is containing all the clotting factors, and then the time which is taken for clot formation is determined in the form of prothrombin time. Now the normal range of prothrombin time is 11 to 16 seconds, and it might vary in different laboratories. Also remember, please, one more thing you remember, please see what is the normal prothrombin time in the laboratory that you are working. In your medical colleges, please you see, because examiners will ask you what is the range in your laboratory, in your college. So it might vary little bit, okay, here and there. Now remember, what are the conditions where the prothrombin time is increased? It can be increased because of, first of all, deficiency of clotting factors of the extrinsic or the intrinsic pathway, not the intrinsic pathway, sorry, of the extrinsic or common pathway. This is a mistake, okay, due to the deficiency of the clotting factors of the extrinsic or the common pathways, because they are assessing the clotting factors of the extrinsic or the common pathway, as we already seen over here, that prothrombin time, they are basically assessing the clotting factors of the extrinsic and the common pathways. Okay, so when there is a deficiency of clotting factors of extrinsic or common pathways, so prothrombin time will be increased. Or if the patient is on oral anticoagulants like warfarin, or the patient is suffering from liver disease, severe liver disease, or vitamin K deficiency. What are the vitamin K dependent clotting factors? 2, 7, 9, 10. Vitamin K is important for gamma carboxylation of these clotting factors. Or in case of DIC, in DIC all the parameters are abnormal. Okay, so what is the use of prothrombin time? It is used to monitor the patients who are on oral anticoagulants, one of the most important use of prothrombin time. Now remember, in this case, when you have to monitor the patient who is on oral anticoagulant, you cannot rely on the prothrombin time alone. So over here in these patients who are on oral anticoagulant, the prothrombin time is reported in the form of INR. INR is called as International Normalized Ratio. Why it is reported as INR? For standardization of results. So what is INR? It is the ratio of prothrombin time of the patient to prothrombin time of the control to the power of ISI. What is ISI? ISI is International Sensitivity Index. Okay, and this is different for different companies who are manufacturing different types of tissue thromboplastin that we are using. So the manufacturer itself is going to give you the ISI from where you are purchasing the tissue thromboplastin. As we have seen that the tissue thromboplastin over here we are using as a part of the test. So different different tissue thromboplastin reagent is having different ISI which is fixed by the manufacturer. Now remember, why it is required for us to report as INR? Because it is standardizing, it is standardizing the results. So for example, there is not great variations. Remember one thing, that whatever tissue thromboplastin we are using some of the source can be ox, some can be pig, some can be some other animal. So because there are different sources of the tissue thromboplastin, therefore the prothrombin time that you will get, okay, for might vary a lot from lab to lab. So to standardize the result, we are using this ISI. So tissue thromboplastin reagents, they can come from different sources, as I already told you. They react differently to similar deficiencies of vitamin K dependent clotting factors, that is 2, 7, 9 and 10. Therefore, for patients who are on oral anticoagulants, it's advisable to report the PT as INR, as a ratio. Okay, it is done for standardization of the value. And what is ISI? ISI is International Sensitivity Index. It is given by the manufacturer of the tissue thromboplastin reagent, as I already explained. Now remember, for patients who are on oral anticoagulant, the INR has to be maintained between 2 to 3 for prophylaxis. Okay, for patient who are on prophylaxis, prophylactic therapy of, okay, for prophylaxis, okay, as well as for patients who are on treatment for DVT. For both these conditions, the INR has to be maintained between 2 to 3, whereas Those who are having mechanical heart valves, for that the range where the INR has to be maintained is between 2.5 to 3.5. Now remember, this INR is why we are monitoring INR, or why we are monitoring the patients who are on anticoagulants, so as to prevent thrombosis. So if you give too less amount, if you are giving less amount, okay, if you are giving less amount of anticoagulants to the patient, so the patient might develop thrombosis. If you are giving excessive amount of anticoagulant, then it can lead to bleeding as well. So we have to maintain. So how do you monitor that how much amount of anticoagulant has to be given? So you monitor with the help of INR. You have to maintain INR between them. So you repeat the INRs on a daily basis, so as to see whether, not daily basis, when the patient is the patient is admitted for any reason. So you monitor on a daily basis, or time to time you are monitoring the INR levels, so as to calibrate the amount of, or the dosing of the anticoagulant that you are giving to the patient. Second important use of prothrombin time is to assess liver function. Thirdly, for the assessment of vitamin K deficiency, and also to screen for hereditary deficiency of clotting factors of the extrinsic and the common pathways. Okay, so this is all about the prothrombin time, which can be asked as a short note in the exam. Next, we are going to discuss about the APTT, okay, which is also asked as a short note in the exam. Now, what does the APTT do? The APTT